All right, it's just setting up, starting the stream. What I'll do is I'll put us on gallery view. All right, and it looks like we're live. So tonight I have a very special guest, Facebook. This is Dr. Kristen Oliver. She is one of the founders of Bluetail Medical Group, Regenerative Medical Group.
That's right.
And I'll let her tell her about herself. She is more published than most of the people out there. So I'd like to introduce Dr. Kristen Oliver, and thank you for coming on tonight.
Oh, well, Ron, thanks a ton. I appreciate the invitation. So my background, I'm primary care sports medicine. I did my residency in family medicine at the University of Missouri here in Columbia, where I still live. And then I did a 2-year fellowship in sports medicine and got a master's in public health, which, you know, that in a quarter won't buy you a candy bar nowadays. But anyway, but it was a great experience. I remained in the Columbia area while working in one of the ERs here. I met my current partner, my founding partner, Dr. Crane, David Crane, and he and I started first. Dr. Crane had started Crane Clinic, and I had a practice here in Columbia. We, basically merged together and have been together since then. We've added 3 more partners actually since then, and have clinics in St. Louis is our kind of mothership here in Columbia where I live. We have one down in Naples, and then we have a couple up way north. Well, one in Rogers, Arkansas, then one in Green Bay, and then Minnesota. I don't know why we are heading north, especially in February.
Hey, it is what it is, and this is a different thing for me because I've had most of the Regenix physicians on here. I've had PTs, I've had some chiropractors, and what I like to show here is that you can get quality regenerative medicine outside of Regenix, but really you need to find that quality regenerative medicine and make sure that you're finding somebody who's doing it right. And
I totally agree with you. That's a key right now. It's one of the things that makes you and I, in the same boat, right? Even though we may not work for the same company, that doesn't mean that we both want to ensure that people are using quality products in an ethical manner. And that's a huge thing for me.
Yeah. And that's really what you can get. It's something where I talk to my patients every day, and a lot of times they find us because they went searching or they went to somebody and they found somebody who, dabbled in regenerative medicine, and they end up finding one of our names and one of the people that we do or work with because we do quality work, and we're really following the evidence-based medicine protocols that really I believe you've established. And that kind of brings me to my first question for you. 2020, it was a very rough year. There's a lot of things going on with COVID and everything. But what is some of the really the best evidence-based medicine that you've seen come out in 2020?
There was a good article actually put out by Adam Adams. He came out with a good article in 2020. And I can't remember what journal it was published in. And then there was a second article that I just looked at. I'm going to forget the name. I've got it actually on my laptop. I could look it up, but there were probably 2 to 3 good articles that came out. Unfortunately, a lot of the articles that have come out in the last 5 or 6 years are review articles, and everybody seems to continue to review the same thing. And the problem is what we do there. You can think about regenerative medicine in many fashions. We have what we do, which is primarily percutaneous, right? Applications. And then you have the application that is sometimes performed intraoperatively. So when you get some of these articles, you have to kind of hone down on, hey, is this the same application that I'm looking at as a consumer or not? So, as not only are there different applications, but there's also different devices and for the average patient, the average consumer, let's say, it's very difficult. It's very difficult to get through all of that, to try to decide, okay, who's a quality provider? Who's telling me the truth? I'm going to this dinner seminar where someone says my stem cells are too old, right? And who's telling me I don't have enough. And, all these things that they're like mythical, right? They're not even true. But how do they know who to trust? So all you can do is sort of lay it out there. But if you Google stem cells, there's some crazy stuff that comes up.
Absolutely. And that's really what I mean, essentially what a white paper used to be is really what a blog is nowadays, right? We're in the information age of medicine where people can Google anything they want, and we can get as much information as we used to, go down and go to the library and have to lug back a ton of books or a ton of journal articles and go, oh, here's all your articles. Now you can just go, let's pull that up. Let's pull this up. Let's pull that up. So we're able to pool things so quickly, but it's also the misinformation age too, right? Because that is something where people get so much misinformation. They're led on by these Instagram influencers who really have no business talking about the things they should be talking about. And it's tough to get the blue check mark next to somebody's name like yourself or myself to make sure that, you're getting good information. So,
Right.
That's one of the things that I've kind of noticed. So talking about the articles, review articles, yes, review articles are great. They're looking at, so for anybody's out there, what review articles are is where we pool all these journal articles that have been put out there, and we try to, put them on evidence-based, and we try to look at all of them together and really mash them all together and try to get the best evidence from all of them, and weed them out based on either poor candidacy grades or things that they did that they didn't really look at the right scores. So that's one of the things. One of the articles that I was really interested in, I was curious to see what your thoughts were by Philip Hernegow.
That one just recently came out, the bone marrow of the interosseous
Yes.
application. Yes, that's actually a great article.
Yeah. So how is that, really my question to you is, how is that influencing your practice moving forward?
Well, it's very interesting. We started using bone marrow interosseously about 5 years ago. So, and we did it because we didn't use it initially in osteoarthritis. We were using it in people who had osteochondritis dissecans, OCD lesions, young athletes with OCD lesions. So our approach towards that, so an OCD lesion, what it is there's two types of cartilage, let's say in your knee, or you've got your meniscus, which is the squishy cartilage like the end of your nose. And then you have the hard cartilage that lines the bones like icing on a cupcake. I'm not telling you that because you don't know that. I'm telling the audience that. And so one of the banes of the orthopedic surgeon's existence has always been these lesions where if you think about that hard cartilage like icing on a cupcake and then the bone like the cupcake, it's like someone goes and takes a bite out of the cupcake. So you've lost that articular cartilage and you have unhealthy bone behind it. And so for many years we would do microfracture, or they would try to do allogenic cartilage transplants, which aren't very successful, unfortunately. So there never was a good answer. So we started before that, like 7, 8, 9 years ago, where we would combine with an orthopedic surgeon. They would do a microfracture and then we would treat afterward with bone marrow. And we got some pretty good success. But then we started probably like I said, 5, 6 years ago, where we would actually just place the bone. We started doing it under fluoroscopy with a jam sheety, a big needle, to place the bone marrow interosseously and then also place it in the joint. So interosseously means in the bone. So we would sort of, let's say the lesion was in the femur, we would drill into the bone, place it in the bone itself proximal to the lesion. He's going to draw a little picture here. That's better than mine. You're pretty good.
Thank
You're a little art teacher.
Interesting on the art class.
That's pretty good. And my distal femur usually looks like a butt. So yours looks a lot better.
So yeah, in here, correct?
Yeah, we would go actually directly, not quite so shallow, a little more deep, almost perpendicular. Because we didn't, all you've got to do is flood that area with bone marrow. You don't have to get it right into the lesion. So we would place, 3 cc's of bone marrow aspirate concentrate in that area. And then we would also treat intra-articularly. And we were getting excellent success, 30, 40, 50, 60% regeneration of that articular cartilage. Now, we never were able to go in operatively and take a piece out. We never checked if it was hyaline or fibrocartilage, but patients' pain got better and they got back to their sport or their activity without pain. So then we took that a step further. If you get an MRI on someone who has stage 4 osteoarthritis of the medial compartment, you'd see all the same edema in the bone, right? Yeah. So same idea. So I've got this swelling in the bone. Now the bone hasn't formed a lesion yet, but that bone is causing pain. Yeah. So our success with like stage 4 medial compartment osteoarthritis was probably only like 60% back in, before we started interosseously placing it. But now we've added that and it's really gone up to about 85% of our patients get, at least a 75, 80% improvement in pain and function. So that's a game changer. So seeing Hernegow put that article out was awesome. I don't have the minions or the money to be able to do a study like that. And it's awesome that he's been able to do that. So,
in putting this in I like to make people really understand it. So 17 out of 20 patients would get about if you went from if you're at a 7 out of 10 pain, they'd probably go down to like a 2. Is that what you're saying?
Correct. Where they could do most of their activities without a lot of discomfort. If they were going to go for, like I have a lot of farmers in Missouri, if they were going to go out and have to work their cattle for a long day in the cold weather, they would be sore, but by the next day they'd feel okay. Enough so that they didn't feel like they had to go get their knee replaced.
So you're doing all in the bone, like 3 cc's, then you're also doing inside, correct? Interarticular?
Yep. And treating any other issues, any soft tissue issues. You guys have a similar approach at Regenix as we do, where you're treating the knee is sort of like an organ. It's not just one shot intra-articularly. You have to treat it you have to be thorough about determining what are the pain generators to get patients, because if you don't, patients won't get an optimal outcome.
Absolutely. And this is great. Like this really, for me is, I think, a game changer, because I really like the part of he had the one article that talked about this, and he also had the one article with the biggest question. People go, so how many years do I get, doc? Right? How long does it last? Right? So the biggest thing, my biggest takeaway was, I believe it was 4 out of 5 patients would get enough relief that they didn't have to have a knee replacement at 15 years.
Yeah, that's that amazed me. That's amazing to me.
I'm like mind blown. I'm sitting there going, like, 15 years. And when you tell a person that they have a chance to get 15 years, that there are 4 out of 5 patients are going to get 15 years out of a treatment versus, oh, hey, we'll get 2 to 3 years out of it. That's a big game changer, I think, for us as a whole. And I think that what you're saying is fantastic. I actually really love that approach. Like, you're going, I like to attribute it to agriculture. So I'm not only putting, fertilizer down on the joint itself, right? I'm not just putting it interarticular. I'm also going in and tilling the undersoil, tilling that subchondral layer, and really making the bone healthier beneath it, so that we can get really good healthy cartilage on top. I try to get healthy.
Funny you say that, because I've always said that, like, the stem cells are like seeds. Platelets have growth factor. It's like fertilizer. But sometimes if you have really bad dirt, it's the exact same thing. So you and I are saying that you're going in and trying to, because that's where the blood supply comes from, the bone. That's where the blood supply comes. And if you have all that edema and swelling in the bone, you're not getting good nutrition to that bony that cartilage, that layer between the bone and the cartilage, which is required in order to have less pain. So, intra-articularly, we can place cells and improve the synovial milieu and decrease inflammation. But if you don't, stop that overproduction of interleukins and
metalloproteases,
and proteases, MMPs. If you don't decrease all those inflammatory particles, you want to just not kind of improve in the joint, but you want to stop them from forming. So,
and I've actually asked this question to my colleagues. I'm thinking to myself, it's like, I feel like sometimes PRP does really well for a lot of soft tissue stuff, sometimes like concentrated PRP. So hey, you got a little bit of a MCL, a little partial tear coupled with really an articular cartilage defect. Is it really putting the BMAX subchondrally? And then what are your thoughts about fat, right? Do you throw fat in at all? All
right. So the fat is a hard topic. We don't use fat as a source of stem cells, obviously.
No, absolutely not.
Yeah. And if anybody's considering using fat at all, you're going to have to go through the FDA and get an IND.
Absolutely. Yeah.
So I think that's going to be a game changer in May. We have previously used fat as a matrix in soft tissue injuries. We do not use it intra-articularly. I don't think it gives any benefit intra-articularly necessarily. Now, there's no study that has bone marrow alone, bone marrow fat intra-articularly. Now, Chris Centeno did the article where he compared bone marrow intra-articularly. He had a subset of patients with bone marrow concentrated interarticularly and soft tissue, and then just bone marrow fat intra-articularly, which is what we don't use. It's kind of the opposite, where we're actually applying the fat is primarily not used intra-articularly, but it's used as a matrix anywhere there's a soft tissue tear. So let's say you've got a partial tear of your MCL, or you've got let's say a quad tendon tear or hamstring insertional tear. That kind of stuff is where I primarily use the adipose.
And I've talked to, I've actually reached out to Jerry Malanga a couple of times, because he's a great resource, and I'm always asking him about questions and what he would be doing, because he's done this a very long time as well.
Yes.
I asked him about Mfat, because he has the lipogems. He's a big lipogems guy. So I was just curious, and there was a big uproar when what was it, AAOM, when who was the FDA person who said no with fat?
Oh, well, that would happen in 2017. It was before Peter Marks was there. Oh, he's the guy who wrote the paper in 2000, and he wrote in 2017 the position statement. He was the predecessor to Peter Marks with cyber. And I'll think of his name probably before we finish this, because it was on the tip of my tongue for a really long time.
Yeah, but Peter Marks was the guy that I'm referring to in the most recent one of the online like virtual conferences where he was asked a question kind of off the cuff, and he then went back and retracted some of his remarks about fat because of certain things. Now, you know, Regenix.
That's going to be very interesting. I know Regenix. So Mfat and fat. So there's SVF, right? So there's taking fat, manipulating it. Yep. So if you really want to use fat as a source of stem cells, quote unquote, you need to use a collagenase or an enzyme to break the fat down. To release the ends. And so SVF has been studied over and over and over again, and is obviously been shown in a lot of offshore papers to be very effective as a source of mesenchymal stem cells, right? Mfat's a little different. Mfat has an FDA clearance to be used for intraoperative orthopedic use, but it's this broad subject, right? Or I think there's like multiple applications for it, if I remember right. But anyway, the question is going to be, and I don't think we know this answer, is the FDA going to recognize Mfat as something different than non-manipulated adipose or SVF? That's $1 million question. Yeah. And the FDA, whenever I've seen them asked about it, they kind of hedge around it, right? It's sort of this edgy thing. So I don't know the answer, but here's how I feel about it. I'm not saying Lipogems is not a quality product, because people get great results with it, but I'm sort of like, hey, I use bone marrow concentrate and PRP. I've been using it for years. I get great results. I find it less invasive than taking fat out. I mean, you want to get 80 cc's of fat, unless somebody's pretty fluffy like you. I couldn't get 80 cc's of fat off you, unless you're hiding something below camera.
No, I'm not hiding anything below down here.
So, you know, so to me, it's sort of like, hey, I've driven this car for a long time. It's reliable. I get reliable results. I'm comfortable doing it. So it's sort of like, if I don't think the other is going to give me a better result, I'm not going to jump the tracks.
So I 100%, I'm right there with you, because when I first started about a little over four years ago with Regenix, all we did was BMAC. We didn't even touch fat. Fat was not in the options. And just to clarify, with anybody who's a lay person out there, what is SVF? It's stromal vascular fraction. And what stromal vascular fraction is you use an enzyme to break down the fat, which then releases stem cells. Now, you and I could have a discussion about whether stem cells are what's actually doing the work.
Oh yeah. What is it like?
That could go for days.
We could,
so we'll kind of just leave that for future time. So that makes it a drug in the eyes of the FDA. And that's why we talk about offshore results, right? Offshore results, anything outside the United States, because the FDA will not allow SVF here. So I wanted to clarify that with you, knowing I know my stuff on that. So I'm very, very, very tight on that. Now, Mfat's something that Regenix, Kristen was totally against, wasn't going to do it. And then he saw that, that paper, I think the BMAC versus Mfat from Robbie Bowers and Malanga. Not Malanga. It was Motner, Ken Motner.
Oh, Ken. Okay.
Yeah, from Emory. And it really showed that BMAC versus Mfat, they did a comparison arm, a cohort study, and they found that both had really favorable outcomes.
Correct.
So I'm right there with you. I'm a BMAC true and true. Now, here's where I kind of like to use it, and what I'll, because it is a tool in our toolbox now, is that, hey, that person who's had BMAC didn't have the results we expected, right? And that person's really trying to avoid a knee replacement, or they're really trying to avoid that surgical procedure, and they're looking for an alternative. You got to have it. Really kind of gives me that option, and we don't know. Some people really respond. Everybody's different.
Everyone's different. And the biggest issue is that we don't have the ability yet to know. We can't do a bioassay on a patient and say, okay, this organism, the patient, is going to respond better to this application or this intervention. Okay. I think that that's the case. I think that there are some people, you and I both know, I have some people I do bone marrow on, they walk out and they say, I've never had pain since. And you're like, well, that doesn't even make any sense. Right. No. I mean, it doesn't, but but everybody's different. And I believe that what we're going to hopefully find as time goes on is that there are people where Mfat they respond better to Mfat, and there are people where they respond better to bone marrow. Now, I can tell you, if I used Mfat more in my practice, because I don't yet, but if I did use it a little more, a lot of it might be patient's body habitus, right? There are some people it's difficult to get bone marrow out of, or people who are paranoid of bone marrow. But the idea of getting 80 cc's of fat, they're not worried at all, right? I have an NFL athlete who has, 4% body fat. I'm not going to get fat from them. So I think at some point, remember, people feel like, what they have to remember is that, we've been doing this at Bluetail for 15 years now. Okay. And I think Chris has been around about that long, if I remember right. Yeah. And so, yeah, about the same. And so, I mean, this is in its infancy still. Yeah. And it's difficult to study because organisms, the patient is different in every case. Devices are different approaches. But boy, the amount that where we've come in the last 5 years compared to where we were in the first 5 years is astronomical. Oh, so, yeah. And I think all you can do is continue to follow the white paper, continue to follow, talk to your peers, and direct patients. Like I direct people to you guys all. Like I had someone from California who called me not too long ago. And I said, hey, you know what? The guys in Regenix do a great job. Go on out there, see them. You don't have to come all the way to Missouri. Not like this is the greatest destination on earth. And especially with COVID, right? Nobody wants to really travel. So, I mean, I like you think that we don't know as much as we're going to know someday, but I believe that someday what I'd love to see is that we determine, like, is there a bioassay we can do on a patient that'll help us know, hey, who's a good candidate for which of these options?
100%. And that's really what I think that there's no, I feel like a lot of people talk about there's got to be a single solution. It's like everybody's different. Everybody's personalized. Everybody responds to things differently. That's really where medicine is going to, more of a personalized approach anyways. So really, I think that's a fantastic thing to talk about. Just kind of like to, just kind of make sure I try to keep this under 30 minutes. We're at the 25 minutes now. I want to make sure people, I don't like taking too much people's time, but we've hit on a couple good topics. If you could do, the conference is coming up in 2021. What are the conferences that you would go to?
Oh gosh. So, what ones are live or not live? I am hoping to go, well, I don't think it's going to be live, but I'm going to go to AMSSM, just because I think that's a good one. Toby, obviously, and then I think that the AAOS is going to do another orthobiologics course in the spring or the fall. It was planned for spring of last year, and then they had to cancel it because of COVID. Those are ones I'm going to go to. And then ICME, I might go to the, cellular medicine conference, but definitely I'll go to AMSSM, Toby. Those are the two kind of mainstays that I go to. And then if AAOS has a meeting where they do have an orthobiologics arm, I'll probably go to that too. Obviously I'm not an orthopedic surgeon, so a lot of the stuff that they discuss, it doesn't apply to me, but I love going to learn what, if my patient comes to me with something and there's a good surgical, something that I feel they can provide with the surgical option is a better option than I can provide through an orthobiologic. I want to make sure I know that so that I can speak with some knowledge and not feel like I don't know what I'm talking about.
Yeah, I did, so my background, just kind of, so, I did a lot of orthopedic surgery, and that's what I thought I wanted to do. And at the end of the day, I ended up doing the same route as you, family medicine, sports medicine. And then, I ran into my colleague, Dr. Lieber, and, here I am. So, awesome. But I did a lot of orthopedic surgery, my third year in medical school, my orthopedic surgeon was pretty much let me pin hips. So, so it was, I got a lot of hands-on experience. And, it was one of those things. I got led down this path, and I feel like this is the best path. I feel like this is the path that's really starting to, it gets patients better. And it's interesting you say that, because, when I looked at, when I started, actually Dr. Crane started before me with PRP. And when he called me and told me what he was doing, I was like, are you smoking crack? I mean, what are you talking about? But as you look at cell biology and you look at how it works, it made perfect sense. And we started treating, the people we started treating with PRP were people who had failed everything else. I mean, they had anterior knee pain where there was no good surgical option. They had multiple lateral releases, and they had no other choice because of the chronic pain that they were experiencing. And to be able to help those people was a game changer for me, and so, it was one of those things where I decided,
this is something that makes people better. And even if at that point, everybody thought we were just voodoo people, I said, I don't really care what people think. What I'm doing is safe. And I feel like it's effective for a certain patient population. And so, and we were very picky about who we chose to do it on, and wanted to make sure they got good results. And like you, it becomes sort of this passion where you feel this drive to, and it's not so much that I feel a drive to inject every patient. It's that I want them to get good quality care, and whatever that decision is that they make. And I think you feel the same way.
Absolutely. And that's why all of our initial evals are just so for the person who's just maybe tuning in on this for the first time. We do an hour-long eval on every first initial eval.
We do same thing.
Yep. We really get to know the patient. We want to know where they've come from, what they've gone through, what their goals are. We try to give them realistic expectations on what they can expect. The worst thing is, the people who are out there, and that's why I wanted to make sure I brought you on and show people that, listen, you got to find the people who are doing this right. There are people who are trying to build Medicare codes and doing all these crazy
terrible stuff. Yeah.
And doing these like amniotic and products that are not stem cells. And we haven't been able to find that. Is there, so from your perspective, is there an amniotic or umbilical product that has any stem cells in it?
No. So we sent about 20 samples off. In fact, Chris and I, Centeno and I have done some talk back and forth. Yeah. So we sent about 20 samples off to an independent lab, and only 1 or 2 had any stem cells at all after they were thawed. Now again, amnion, never any stem cells. Okay. Amnion does not complain. It's just growth factors. But so after thawing, a few products had a few cells, but they weren't bioactive, so they didn't do anything. There's some proteins in there that are anti-inflammatory. You might get 6 months of relief like you might with a hyaluronic acid injection, but that's all you're getting. So these people are charging them $4,000, $5,000, $6,000 for a $750 product and calling it a stem cell product. I mean, to me, those people need to be shut down.
Yeah. And I don't know if you read any Chris's recent blogs, but
yes, he and I are bang the same. We get on the same soapbox.
Listen, I love it. I mean, Chris is great. He's from Florida, so hey, Chris, when you watch this, I know he's like always scavenging stuff, so he's gonna see like, Dr. Torrance got on. I may get an email tonight. Just letting you know that.
No, he's one of my. It's interesting because I think when we first started, there weren't a lot of players in the field, and there was a little competitiveness, right? But to me, it's not anymore. I mean, we are all pushing for the same thing. And I've actually sent a patient to Chris, a very complicated neck patient to him. It's something that I wouldn't touch with a 40-foot pole. But to know there's somebody out there who will take care of like atlantoaxial stuff, it's great to have.
Yeah, those C0, C1s, like no thanks. No thanks. No.
Exactly.
But no, it's good. It's good to hear. It's good. It's refreshing. We've got to really band together as regenerative medicine physicians, and we are really creating this field, like you said. I appreciate your time.
Yeah, I appreciate you too, man.
No worries. We'll have to do this again sometime. I really, I feel like we both kind of, definitely ping off each other, and look forward to seeing maybe at a conference. I'm probably going to do the virtual IOF. Toby, I supposedly signed up for it last year. It was virtual. I don't know if I ever did it. I'm living in it. I've got a colleague, like 2 colleagues that I run into all the time. We talk about it all the time. So we're always bouncing things back and forth, but I appreciate having you. I'm glad that Courtney linked this up. And then what's the best thing to do for this, by the way? This will be saved on our Regenix Tampa Bay, just so you know, and everybody else knows. If you're looking for a consult from us, or I'll put your website on there too for your people in that area. And what you can do is you can share this on your page, and people can learn from it. That's really the biggest thing that I do with these Facebook Lives. It's good information that people can trust.
Well, appreciate you greatly. Thanks for doing this.
All right. Have a great night.
Have a good one. Bye-bye now.
Bye.